Good evening and welcome to this Clinician and Patient Education Series webinar. This is the third of the series, and this is titled Spondyloarthritis and Psoriatic Arthritis Treatment Update. This has been made possible by an educational grant from Pfizer, and the four organizations which are bringing this to you are Spondyloarthritis Research and Treatment Network, that is SPARTAN, Group for the Research and Assessment of Psoriasis, Psoriatic Arthritis, that's GRAPPA, Spondylitis Association of America, and National Psoriasis Foundation. My name is Atul Deodhar. I'm a professor of medicine in the Division of Arthritis and Rheumatic Diseases in Oregon Health and Science University, Portland, Oregon. And it's my distinct pleasure to tell you about the agenda. We have first the patient perspective about the treatment updates. And we have two patients joining us today, Ross Tolliver and John Latella. I will introduce them in a minute. After that, we will have a treatment update lecture by Dr. Anand Kumthekar. I'll introduce him as well. At the end of these three presentations, we will then have panel discussions and we will answer your questions. So you can ask questions anytime in the chat part, and then we will be monitoring that and we will try and answer your questions. So the first part is the patient perspective about the treatment updates, and it's my distinct pleasure to welcome Ross Tolliver. Ross is a 57-year-old wife, mother, and teacher from California. Her diagnosis of ankylosing spondylitis was delayed for nearly 30 years, despite her numerous symptoms and a very strong family history of the disease. Today, Ross manages her condition with a variety of medication, medical devices, as well as daily exercise and recreation. And since her diagnosis in 2018, she has volunteered as an advocate for herself and others with ankylosing spondylitis by leading support groups, serving on patient advisory boards, and participating in awareness projects. Welcome, Ross.
Thank you, Dr. Deodhar. Hello, everyone. As he mentioned, my name is Roz Tolliver, and my life with ankylosing spondylitis has been a roller coaster that I got on 45 years ago. I was 12 in 1977 when I was diagnosed with lung inflammation and persistent neck and shoulder pain. And then at 16, I started getting this unexplained chronic fatigue and fever. And then years later, I was in the Navy in my early 20s when I started getting chronic back and knee pain and stiffness. And my flares weren't frequent then. And because I was young, I bounced back quickly whenever I did have any. And my treatment then was a lot of bed rest, narcotics, and mostly passive physical therapy, no exercise really. And then over the next 30 years, I developed a variety of symptoms all over my body, particularly chronic pain and inflammation in 8 peripheral joints from my shoulders down to my feet. I've had inflammation also in my eyes, lungs, esophagus, and stomach. And my treatment during this time, because I had so many problems, it got really expensive. I was on, NSAIDs like ibuprofen for the inflammation, and then a variety of narcotics for pain. I had physical therapy, chiropractic care, massage therapy, started using a TENS unit, braces, particularly for my knee and elbow, numerous steroid injections, and then I had a lot of pain management procedures in my back and 10 joint surgeries. Now, despite all these symptoms and also a strong family history of SPA, as Dr. Deodhar mentioned, I wasn't diagnosed until 2018. For years, I would tell my providers that my father's spine was completely fused and he was legally blind from chronic uveitis for like 50 years. And also that my brother had SPA and ulcerative colitis, so that they would check me for SPA as well. Now, unfortunately, all the providers I saw based the diagnosis on being positive for the HLA-B27 gene, and I'm negative. So the doctors I saw believed you could not have one without the other. So some providers, they just treated isolated symptoms, whatever was going on at the time. And then some did try to make a connection between them. One doctor said I had fibromyalgia and put me on medication, but the treatment didn't resolve my joint pain or fatigue. And then others misdiagnosed me with lupus and rheumatoid arthritis, but none of them ever even referred me to a rheumatologist. So after 30 years of wondering why I had so many chronic health problems, it was actually a nurse practitioner who suggested I see a rheumatologist. And since I believed I had AS, but I knew that my negative HLA-B27 status was going to be an issue, I started to do research online and learned that about half of African Americans with AS are negative for HLA-B27. So I then referred myself to a rheumatologist, and he diagnosed me within weeks. And I was so relieved because a lot of family and friends thought I was a hypochondriac with all these issues. And so I cried in the parking lot afterwards. I was so relieved to have a diagnosis. And that rheumatologist, he put me on a biologic right away because of my delayed diagnosis. And then I also had active disease. And it was the first time that I was prescribed a medication to prevent my symptoms rather than just treat whatever symptoms I was having. And it worked on my fatigue right away, which was great because that was by far the worst symptom for me. Now, besides my biologic, I also manage my disease with what's worked over the years through trial and error. I use a lot of topical medications, still use braces. I stay active physically to the best of my ability and mentally. I listen to my body and I rest when I need to. And then I also get emotional and physical support when I start to struggle. And that was something I had to learn to do. So my life with spondyloarthritis, say that 3 times fast, is in a word, bittersweet. On the one hand, I'm trapped in this unpredictable body, pain, that I deal with all the time that hampers my ability to earn a living, and also do a lot of the things that I once enjoyed. And I even had to get counseling because I did have trouble coping, with this new normal. But on the other hand, I'm fortunate that my father had it and I grew up with it. And so he taught me unknowingly, because he died years before I got diagnosed, how to keep going in spite of the pain and the limitations, and to find new hobbies to replace the ones that I could no longer do. So I've gone through hell with this disease, but I feel like it's made me more resilient. And then I've met a lot of wonderful people, like the people in this group here, that I wouldn't have otherwise. So thank you. And I'll pass it back to you, Dr. Deodhar.
Thank you so much, Roz. That was an inspirational story. Our next speaker is John Latella. John is he's an 80-year-old male living in Connecticut who was diagnosed with psoriatic arthritis in the 1970s while serving in the military. Now, John receives his treatment from the VA and has been through just about every treatment available. And just like Roz, John also has a very inspirational story to share.
Good afternoon. My name is John Latella. When I was 34, I was diagnosed with psoriatic arthritis. I really didn't have any symptoms other than the fact that the VA wanted me to go through this extensive diagnosis. I spent 4 hours at a VA hospital in Providence, Rhode Island, going through a lot of x-rays. And in those days, x-rays took quite a while to develop. That's why at the time it was so long. And for a long time, I really didn't have any medications. I really didn't even know what psoriatic arthritis was. I couldn't get on the internet because there wasn't any. Over time, I think more of what I've done is personal. The one thing I did after I was diagnosed in 1979 is I quit smoking. I quit smoking because I had bronchitis. And my PCP said, "You want bronchitis next year, keep smoking." I went home and I quit smoking cold turkey. And I had nicotine withdrawal for at least 2 weeks. It wasn't the most pleasant thing to go through, but I think it was the best thing that I ever did in my life. Well, as I went through time with the psoriatic arthritis, about the only thing that the doctors would recommend I take was Tylenol to reduce the pain. But in 2005, I went to a conference with the National Psoriasis Foundation had in Chicago, and they had a presentation on biologics and what they could do, how much they could stop the progression of psoriatic arthritis and help with psoriasis. I went back to the VA that same year, 2004, and asked if I could get on one of the biologics. I said, well, the FDA hadn't approved it yet for psoriatic arthritis. As soon as they do, we'll let you know. Well, the next time I went back to the VA, which is every 3 months, they said it was approved, so I said, can I go on? I went on the first biologic, and it cleared my skin 80% in 45 days. And it seemed to stop the progression of psoriatic arthritis. I wasn't as achy as much. I could move rather fluidly. And that was in 2005. I've been on, in 2006, the first biologics I was using stopped, and I was getting flares back from psoriasis. So they switched me over to another biologic, which I've been on since 2006. So total biologic, I've been on 17 years. I have not had any side effects. It hasn't, and I continue to take it. I can see after the period of times that I take it, when I get to the point where I'm going to take it again, I can feel a little bit of, not anxiety, but achiness in my body with the psoriatic arthritis. I think it's very important for patients to ask their dermatologist to refer them to a rheumatologist to determine whether they have psoriatic arthritis or not. I tell patients that I work with that I have nails that are grooved. My toes are like sausages. And these are two indications of psoriatic arthritis. And if you think you have anything like that, and you have psoriasis or psoriatic disease, go and get tested. It usually takes x-rays. I don't believe, I may be wrong with this, that there's a blood test that you can identify psoriatic arthritis yet. I mean, there's one to come, I'm sure. But be proactive. Don't decide you'll wait and see. Doesn't help to wait and see. You don't want deformed fingers. I've seen people with deformed limbs. Sausages is worse than mine. So just you have to learn to be proactive and take care of yourself. I appreciate the time. Thank you.
John, that was absolutely amazing. These types of stories, they're inspirational even as doctors to us when we see these patients, when I see Roz or John type patients in my clinic. Despite all these adversaries in their life, they still keep going forward with hope and with convictions. Amazing stories. Our next speaker is Dr. Anand Kumthekar. Dr. Anand Kumthekar is Assistant Professor of Medicine. He's also the Director of the Spondyloarthritis Clinic in Montefiore Albert Einstein College of Medicine. And Dr. Kumthekar is going to tell us about axial spondyloarthritis and psoriatic arthritis treatment update.
Thank you everyone for joining us for this third module of the CAPES education series. My name is Anand Kumthekar, and I'm an assistant professor at Montefiore Einstein in New York City, and I'll be talking about treatment updates in axial SPA and psoriatic arthritis. So this is a brief agenda of my talk. We'll briefly spend some time to understand the spectrum of spondyloarthritis diseases. We'll go over the general management principle of spondyloarthritis, and then we'll dive deep into the medications for axial SPA and psoriatic arthritis. So for this talk, the two entities that I'm going to focus on for axial spondyloarthritis, one is non-radiographic axial spondyloarthritis. This means patients who have MRI evidence of inflammation in the sacroiliac joint and their X-ray is normal. And second is radiographic axial spondyloarthritis, which means patients who have X-ray of the SI joint showing damage from long-standing inflammation. And then when we talk about psoriatic arthritis, I'll be referring to patients with inflammatory arthritis, either peripheral or axial. So peripheral meaning affecting either the hands or the knees or the ankles, and axial meaning involving the spine, and which is associated with psoriasis. And some associated feature with PSA, which are enthesitis, which is inflammation of the enthesis, like the Achilles tendon, dactylitis, which means entire finger swollen up like a sausage, or uveitis, which is inflammation of the eye. So I'm going to start off with some general management principles, which are important for both axial spondyloarthritis and psoriatic arthritis. So let's start off with some general health measures. I think education is a key component for treatment of these chronic diseases, as they are lifelong diseases that patients have to manage. Understanding what the diseases entail and what might they expect is very important. There are patient support organizations like Spondyloarthritis Association of America and National Psoriasis Foundation that have excellent resources for patients to navigate the complex management pathways. Patient webinars are a good source of education to get up-to-date information about the latest treatments. And advocacy also is an important part so that patients can really voice their opinions about things that are important to them when managing these conditions. There are certain lifestyle changes which really help in managing both axial spondyloarthritis and psoriatic arthritis. Smoking has been shown to cause worse disease, and of course, it affects the quality of life. Weight management. So obesity, we think, is a pro-inflammatory condition, and it has been linked to development of psoriasis and psoriatic arthritis. Also, patients who are obese, they have higher disease activity score, meaning they have higher levels of inflammation and active disease. And also they respond poorly to certain medications like TNF inhibitors, which we will go through. We always get asked, and patients are curious about dietary interventions or dietary patterns. There's no specific diet that is recommended or endorsed, but a healthy diet which can be adhered on a long-term basis is important. Sleep and stress management is also key, and mindfulness has shown to improve pain perception in patients with chronic diseases. So this is a busy slide, but this is the 2019 ACR SAA SPARTAN treatment recommendation for axial SPA and non-radiographic axial SPA. So I'm going to start off with focusing on this small box here because it gives us some important information. So something that is in dark green, it is something that is strongly recommended by the guidelines, and the light green is conditionally recommended by the guidelines. They divided this for patients with active disease and patients with stable axial disease. So as you see, the dark green boxes are NSAIDs, or non-steroidal anti-inflammatory drugs, physical therapy, certain biologic medications like TNF inhibitors, which are second-line therapy. So for patients who fail first-line therapy like NSAIDs and physical therapy, and then secukinumab and ixekizumab, which are IL-17 inhibitors, are also strongly recommended as third-line therapy. So going over these individual aspects, physical therapy has shown to be extremely beneficial for patients with axial spondyloarthritis. It improves pain, it improves function. Home exercise program has shown to be better than no program. and supervised group physical therapy is better than home exercise program. So overall, getting physical therapy in some form is extremely important and beneficial for patients with axial SPA. And there was a Cochrane review which synthesized data from multiple different trials and studies, and that concluded the same thing, that patients with axial spondyloarthritis should get physical therapy because it improves in pain, function, and overall quality of life. What about NSAIDs, or non-steroidal anti-inflammatory medications? So this is the snapshot from the 2019 treatment guidelines for axial spondyloarthritis. As you see, NSAIDs are in the green box, so they are strongly recommended. For patients with active disease, continuous NSAID is recommended. And for patients with stable disease, on-demand NSAIDs are recommended. There are different types of NSAIDs available in the market. Some of them, like ibuprofen, naproxen, are over the counter. And some, like diclofenac, celecoxib, meloxicam, are prescription medication. The guidelines don't recommend one NSAID over the other. And if a patient is doing well on a particular NSAID, has improvement in pain and function, and does not have side effects, there's no reason to switch to a different type of NSAID. The second thing is, are NSAIDs useful in preventing disease progression in axial spondyloarthritis? So the research data here is a bit conflicting. I'm going to show you data from your 2-year study, which looked at celecoxib, which is a prescription non-steroidal anti-inflammatory medication that was given to patients with axial spondyloarthritis. And the study showed that patients who took NSAIDs on a continuous basis and a high level of inflammation, which was measured by a blood test called C-reactive protein, they had the least progression in terms of their disease, which was measured by something called as NSAS. So apart from this, NSAIDs also improve pain. Around 70% of patients will have some response to NSAIDs when they have axial spondyloarthritis. They also show improvement in level of inflammation, which is measured by a blood test called as CRP. It also shows improvement in imaging, like bone marrow edema, when we perform an MRI scan. And as I mentioned previously, the data about disease progression is conflicting, though studies have shown it prevents or slows down disease progression for patients with axial spondyloarthritis. Of course, NSAIDs come with a lot of side effects, so there should be a healthy discussion between the patient and the healthcare provider whether the medication is right for him or her. Some of the side effects that we worry about are hypertension with long-term use, heartburn or stomach ulcers, kidney problems, liver problems. NSAIDs can also cause fluid retention, and long-term NSAID use is associated with strokes and heart attacks. Moving forward, beyond NSAIDs, over the last 15-20 years, a number of biologic or novel therapies have come to the market for axial spondyloarthritis. These are tumor necrosis factor alpha inhibitors or TNF inhibitors, IL-17A inhibitors, and Janus kinase inhibitors. And we are going to talk about all three of them. But before anyone starts these biologic or novel therapies, they should be tested for hepatitis B, hepatitis C, and tuberculosis, because patients, if they have active infection with any of these conditions, they should be treated. And even if they have latent infection, they need to be treated for a while before they start treatment with these agents. So starting off with biologic medications, this is a simplistic cartoon that explains what we might think is going on in terms of why patients get axial spondyloarthritis. HLA-B27 is a very unstable molecule, and it can misfold and can accumulate in the cell and can produce certain inflammatory signals, which are called cytokines. One of them is a TNF, or tumor necrosis factor alpha. So tumor necrosis factor inhibitors, which are these 5 and which we're going to talk about, block the TNF molecule from interacting with its receptor on the inflammatory cells and thus inhibit the downstream inflammatory response. Similarly, IL-17 is another inflammatory chemical, and IL-17A inhibitors are monoclonal antibodies that bind to the protein IL-17A and inhibits its interaction with IL-17A receptor and thus preventing downstream inflammation. And finally, these are JAK inhibitors, which are oral molecules that inhibit the enzyme Janus kinase and interfere with the JAK-STAT pathway, which is critical to transmit extracellular information into the cell nucleus, which is important for inflammation. So there are 5 different TNF inhibitors that are available in the market. There are infliximab or Remicade, golimumab or Simponi, adalimumab or Humira, certolizumab or Cimzia, and etanercept or Enbrel. Most of them, apart from infliximab, can be given as subcutaneous injection, and infliximab and golimumab are the only one that is given intravenous. So you go to the infusion center and it is administered to you. The frequency is anywhere from a week to every 8 weeks, depending on the agent. And now we also have something called as biosimilars, which is available for infliximab, adalimumab, and etanercept, which are like the generic form of these medications, but they are not the original medication. And if you see, only certolizumab is approved for non-radiographic axial spondyloarthritis, but other TNF inhibitors are routinely used to treat non-radiographic axial spondyloarthritis because they are effective to treat the condition. So researchers, when they looked at these medications, they tried to assess, are they effective in treating patients with axial spondyloarthritis? So they do this by something called as ASAS-40 response, which is a composite score that takes into account how the patient feels about their disease, their pain, function, and a couple of 2 questions about inflammation. And if patients have improvement of 40% in 3 or more of these domains, and no more than 20% worsening in one of the domains, then they say they have reached an ASAS-40 response. So you look at the TNF inhibitors, which are in blue, and the placebo group is in red, and around 40 to 50% of patients who receive TNF inhibitors achieve the ASAS-40 response. And usually TNF inhibitors take somewhere around 3 to 6 months to give patients a response to therapy. What about TNF inhibitors in non-radiographic axial spondyloarthritis? Similarly, the blue bar graph is for patients who got TNF inhibitors for non-radiographic axial SPA, and the red graph is for placebo. Again, 35 to 55% patients in the treatment group responded in terms of ASAS-40, compared to around 15 to 23% in the placebo group. So definitely TNF inhibitors are effective in treatment for axial spondyloarthritis. But they have some certain side effects that everyone should be aware about. They can cause injection site reaction, which means pain or burning or redness at the site, which can be easily treated with certain antihistaminics like Benadryl. All TNF inhibitors increase risk of infection across the board, but thankfully the rate of serious infections are low. when you get certain medications like infliximab, it can cause an allergic reaction like swelling of the lips, difficulty breathing, low blood pressure, or just simple hives, which can be managed in the infusion center. And rare side effects include neurological disorders like neuropathy and multiple sclerosis, which are thankfully very rare. What are types of IL-17A inhibitors? So there are two IL-17A inhibitors that are approved for AS and approved for non-radiographic axial SPA. One is secukinumab or Cosentyx, which is an injection form and can be given monthly after a loading dose. And then the other is ixekizumab or Taltz, which is also a subcutaneous injection, which is given monthly after initial loading doses. So this slide shows the data about IL-17 inhibitors in patients with ankylosing spondylitis and non-radiographic axial SPA for IL-17A inhibitors. So as you see, the blue graph again is the treatment arm, and around 35 to 48% patients in the treatment arm respond to IL-17A inhibitors compared to around 18% to as high as 29% in the placebo group. Again, this is for patients with ankylosing spondylitis who receive secukinumab, and this is for non-radiographic ankylosing spondylitis who receive secukinumab. And the last two graphs are for ixekizumab in AS and non-radiographic axial SPA. IL-17 inhibitors, as they're biologic, they also increase the risk of infection. There is a higher risk of a fungal infection called candida infection, but thankfully they are not very severe. They can be oral candida, vaginal candida infection, which can be treated with antifungals. IL-17A inhibitors can flare inflammatory bowel diseases, so it is better to avoid these agents if possible. Moving on to JAK inhibitors. So there are two JAK inhibitors approved for ankylosing spondylitis, which is tofacitinib or Xeljanz and upadacitinib or Rinvoq. None of them are approved for non-radiographic axial spondyloarthritis yet. These are oral medications, which is a big plus for these medications compared to injections. And they can be given once a day or 2 times a day for tofacitinib, and upadacitinib is given once daily. Again, looking at data, if they're effective for patients with axial spondyloarthritis, again, these are not head-to-head trials. This trial looked at patients receiving tofacitinib in ankylosing spondylitis, and 40% patient responded compared to 13%. And these two trials looked at upadacitinib in AS and non-radiographic axial spondyloarthritis, with 45 to 50% patients in the treatment arm responding compared to around 20 to 25% in the placebo arm. Again, JAK inhibitors also increase risk of infection. We are a bit more cautious in terms of zoster infection, and if possible, patients should get their zoster vaccine before they start on a JAK inhibitor. A recent study that came out in 2022 prompted the FDA to put a warning of increased cardiovascular events like heart attack and stroke and cancer in patients who receive JAK inhibitors. Of note, the study was done in patients who had rheumatoid arthritis and receiving JAK inhibitors, and not for patients who had psoriatic arthritis or ankylosing spondylitis. But it is important to know about these new warning labels that have come up with the JAK inhibitors. Now, moving over to psoriatic arthritis, GRAPPA updated their treatment recommendations for psoriatic arthritis this year. And they recommended that we should use a domain-based approach because psoriatic arthritis is such a heterogeneous disease that can affect the peripheral arthritis, the axial disease, enthesitis like the Achilles tendon, or dactylitis, which are the musculoskeletal domains. Or it can cause skin issues, which are the major burden for patients, which is psoriasis or nail disease. And certain patients can have extra musculoskeletal domains like inflammatory bowel disease and uveitis, which need to be managed as well. So there were some key points from the overarching principles of PSA treatment. First, therapeutic decisions need to be individualized because PSA patients can have different burden in terms of the domain that is involved. Like some patients can have psoriasis that is bothersome to them, or compared to other patients who might have enthesitis, which is the main problem. There should be a shared decision between the physician or the treating provider and the patient. Assessment of PSA should be comprehensive and should involve all disease domains that we looked at in the previous slide. There should be assessment that includes patient-reported outcomes, which means these are certain measures reported by the patient which have been validated in psoriatic arthritis and what we think are important to patients. We should always achieve to get the lowest possible level of disease activity and improve functional status. And finally, psoriatic arthritis patients have significant comorbidity burden, and that should be addressed appropriately, like screening for cardiovascular disease, managing obesity, because that has been linked to poor outcomes in PSA. So there are multiple therapeutic options for psoriatic arthritis. There is some overlap with some of the agents that we discussed previously for axial spondyloarthritis, which are TNF inhibitors, IL-17 inhibitors, and JAK inhibitors, along with NSAIDs. Glucocorticoids, if required, can be used in form of intra-articular injections or very rarely oral. And then there are certain other classes of medications which are different for psoriatic arthritis than axial spondyloarthritis, which are conventional synthetic DMARDs like methotrexate and leflunomide, IL-23 inhibitors like guselkumab, T-cell modulators like abatacept, targeted synthetic DMARDs or PDE4 inhibitor apremilast or Otezla, and IL-12/23 inhibitors like ustekinumab. And we are going to go over some of these agents in the next slide. So these are additional medication classes for psoriatic arthritis. I'm not talking about TNF inhibitors and IL-17 inhibitors and JAK inhibitors, which are used for axial spondyloarthritis and can also be used for psoriatic arthritis. So IL-23 inhibitor, example, guselkumab, brand name is Tremfya. It is a subcutaneous injection which can be given every 2 months after a loading dose. You have IL-12/23 inhibitor like ustekinumab or Stelara. Again, it can be given as an injection every 3 months after loading dose. Abatacept or Orencia can be given as an infusion every month or can be given subcutaneously every week. And then the last two are oral medication. One is PDE4 inhibitor called apremilast or Otezla, which is twice daily medication after a 5-day titration period. And last is an old medication called methotrexate, which is effective. It is given orally. It is a weekly medication and has to be given with a daily intake of folic acid. So what drugs classes can be used for musculoskeletal domain? So for peripheral arthritis, axial disease, enthesitis, and dactylitis, NSAIDs, physiotherapy, and glucocorticoid injections are recommended. But if they don't work, you can move down to the next class of medication. So there's a lot of options for treatment. So for peripheral arthritis, you can use synthetic DMARDs like methotrexate or TNF inhibitors or IL-17 inhibitors or IL-12/23 or IL-23 inhibitors and JAK inhibitors or PDE4 inhibitors. For axial disease, TNF inhibitors, IL-17 inhibitors, and JAK inhibitors are recommended. For enthesitis and dactylitis, again, you have a variety of choices of medications, starting from methotrexate to TNF inhibitors to 1223 inhibitors, IL-17 inhibitors, and also CTLA-4 agonists or JAK inhibitors and PDE4 inhibitors, which are oral medications. So there are so many drugs for psoriatic arthritis, and this figure shows how patients with psoriatic arthritis respond to different treatments. So researchers looked at ASAS-20 response, which is 20% improvement in tender and swollen joint count, and 20% improvement in 3 of the 5 other domains. So the first 5 are TNF inhibitors, and you see the response rate is somewhere close to high 50 to 60%, compared to somewhere in the 10 to 20% placebo. IL-17 inhibitors, this have a response rate of 50%. Ustekinumab, which is IL-12/23 inhibitor, has a response rate of 40%. Apremilast and abatacept have a response rate of 30 to 40%. JAK inhibitors, or tofacitinib or upadacitinib, have a response rate of 40 to 70%. And finally, the IL-23 inhibitor guselkumab and IL-23 inhibitor risankizumab have a response rate of around 50 to 60%. So these medications are effective in treating psoriatic arthritis. And I think treatment decision should be based on what domain is primarily involved. What about for psoriasis and nail disease? I think topical procedures are extremely useful. We always get help from our derm colleagues in controlling the psoriasis from topical agents. But if they don't work, there are biological DMARDs or synthetic DMARDs like methotrexate or TNF inhibitors, IL-12/23 inhibitors, JAK inhibitors, or PDE4 inhibitors. Nail disease, which can be a little difficult to treat and can be annoying too. Usually if the topicals don't work, the guidelines recommend to go to biological DMARDs, which are again listed here. And finally, extra musculoskeletal domains can be a feature with psoriatic arthritis. So patients who have inflammatory bowel disease, as we discussed, they should not be treated with IL-17A inhibitors if possible, and other classes like TNF inhibitors, IL-23 inhibitors, or IL-12/23 inhibitors are recommended. They also have options of oral medications like JAK inhibitors or methotrexate. And for uveitis, which is inflammation in the eye, TNF inhibitors except etanercept is recommended, or there's other oral agents like cyclosporin or methotrexate. So in short, there are a wide variety of therapeutic options for psoriatic arthritis. And I think the domain that's significantly involved that should be targeted with the appropriate agent, but agent targeting different domains should be used to get an overall response. So in summary, these two entities, axial spondyloarthritis and psoriatic arthritis, are really chronic diseases that need to be managed over a long period of time. And lifestyle changes are important aspects of their treatment, like smoking cessation and weight management and mindfulness and healthy diet. There are multiple medications available for treatment of both these entities. TNF inhibitors, IL-17A inhibitors are injections, and JAK inhibitors are oral medications that are approved for both. IL-12/23 inhibitors like ustekinumab and IL-23 inhibitors like guselkumab are approved for treatment of PSA, but not for axial spondyloarthritis. And as we discussed, PSA treatment is domain-based, so an agent that can target multiple domains should be chosen. All biological DMARDs increase the risk of infection, and patients should be screened for hepatitis B, C, and quantiferon. And JAK inhibitors may have an additional risk of cardiovascular disease and cancer, but the data surrounding the same is still evolving. So there is FDA warning with the use of JAK inhibitors. With this, I thank you for your time and attention, and I'm ready to take any questions if there are any.
Thank you. Thank you very much, Dr. Kumthekar. That was an extensive and very extensive revision, I should say, of this very complicated topic of medication available to treat axial spondyloarthritis and psoriatic arthritis. I mean, I think it shows me two things. Number one is that we have now so many options available, which actually is a very good thing from patient's point of view, that we have lots and lots of options available to treat these conditions. We do have several questions in the chat. Well, first of all, people have commented how enthused or how sort of inspired they were by the stories they heard from Roz and John, both of you. So there are lots of very nice comments. People have sent heart pictures to both of you. They loved it, what you said. So this one question is, what should I do to help gain a better understanding of my disease? And how should I stay informed? I mean, I'm going to put this question to Roz. Roz, how do you stay informed? And what do you do to get a better understanding of your disease? What have you done over the years? How would you advise? What would you advise to your colleague, another patient?
Sure. So for me, luckily, my need for information came about in the information age. So the internet is your friend. You have access to a lot of different organizations dedicated to our disease. So like Dr. Deodhar mentioned in the very beginning, you have the Spondylitis Association of America, you have the National Psoriasis Foundation, and others. And so all you have to do is Google, just put the disease in the search field, and you'll see a lot of the organizations come up, and they all have really wonderful websites that have a plethora of information. They list, symptoms, treatment options, things that are in the works for the future. They also can connect you with support groups. With the advent of COVID, a lot of those groups became virtual, but that's actually good, because if you're having a lot of symptoms, and then also you don't want to catch COVID, you can just pop on your computer and meet with others, and getting that emotional support, and also learning maybe what worked for others is really helpful. Your doctor, your rheumatologist or dermatologist, whoever you're seeing, they can certainly be a source of information. And then one of the other important pieces for me is social media. Facebook, Instagram, Twitter, they all have a lot of advocates who are online, and people who have accounts dedicated to talking about their journey and how they manage their symptoms. And there are a lot of groups available that you can join online where you can ask questions and learn from others. So there's a variety of things right at your fingertips.
Thank you. Thank you so much, Roz.
You're welcome.
The next question is, maybe I should ask John. How important do you feel, John, to have new treatments developed, and how do you keep a sense of hope for the future? I mean, I think that I always find this myself to ask my patient that once you have this kind of disease, what do you see? I mean, how do you keep that sense of hope for the future?
To me, the important thing was to understand you have the disease and you live. You don't live and have the disease control you. Once I came over that hurdle, then it became easy to move forward and see the hope that was in the future. And from my experience with both psoriasis and psoriatic arthritis, in 1964, when I was first diagnosed with psoriasis, it wasn't anything on that I had. The topicals stained every piece of clothing that I had. I couldn't use them. I was in the Navy. We wear whites. You can't wear whites and have the topicals from the 60s. So I couldn't really do anything unless I had extended periods of time at home. And then as time went by, you saw the progression of more and more people becoming involved in the research of different medications. And it opened up a whole new avenue of hope. Someday we'll get to the point where we'll use the medication. We don't have to worry about flares. We don't have to worry about anything. It won't be a cure, It'll be as close to a cure as we'll ever get.
Thank you. Thank you. I'm going to combine them, and suddenly lots and lots of questions are coming, which I can't even keep up with. I'm going to combine some of them. And so this question, probably I should ask Dr. Kumthekar. There is a question about long-term use of biologics. And can people just keep on using biologics? There is somebody here asking about they have used biologic adalimumab for nearly 25 years or something like that. And then along with that, there is a question that if I have been using these drugs for a very long time, biologics, and I'm doing very well, can I stop them? And will I flare? And will I get a reaction? So, Dr. Kumthekar, do you want to take this question?
Yes, of course. So I think those are excellent questions and very relevant to our patients when we see them in our clinic, because these medications, they do come with risks, and patients always wonder, if I've been taking them for a long time, can I stop them or taper them? So the data surrounding that are the recommendations from the guidelines usually recommend against stopping or tapering the medications. Though the data is a bit conflicting, mostly from observational studies. Usually, if a patient is doing very well, so if they're in remission or have low disease activity, I think these are the patients who are at the highest chance of having a stable disease if they try to taper the medication. So I think tapering is possibly an option. Discontinuation of a biologic, I think there's a risk of having a flare. So I think having a shared decision between you and your treating provider, I think, is the best pathway forward, with a caveat that there's some chance that the disease can flare when you stop the medication.
So there is a question, because people got a little bit worried about the cardiovascular and cancer risk that you said about JAK inhibitor. How big is the risk of cancer and cardiovascular? I mean, what do you tell the patients when you are going to start them? How big is this risk of both these problems?
So as I mentioned, so the data that we have is coming from a large study for patients who were treated with rheumatoid arthritis. And the risk was not across all age groups. There was a slightly higher risk in patients who were more than 65 years of age, who had a higher cardiovascular and cancer risk. So if patients are already taking a JAK inhibitor and if they are stable, I usually inform them about the new FDA guidance. And as patients have gone through so much with the disease and they have done well, in my experience at least, most of the patients, they say they wish to continue the medications. And it's, again, a shared decision and an informed decision by the patient and the treating provider.
Very good. There is a question. Am I understanding this correctly? These medications can actually help control progression of the disease, not just help manage the symptoms? Dr. Kumthekar?
Yes, that's also an excellent question. So for axial spondyloarthritis, the initial studies with TNF inhibitors, there was conflicting data. It showed that it did not slow down progression, but the studies were done for a very short duration, for 2 years or so. But I think long-term follow-up studies have shown that these medications, if they're used for a prolonged time, they can slow down progression of the disease. And definitely biologic medications have shown to decrease rate of erosions and joint damage in patients with psoriatic arthritis.
Yeah, very good. There, in fact, is a question, and I'm keeping in the chat. Actually, we still have time. How do we determine which treatments we use? Is it just what bubbles up to the top? I mean, there are so many choices. You kind of showed this array of treatment, the bar graphs. How do you decide which treatment to choose first?
So that's an excellent question again. So if you look at the treatment recommendation, if we go for axial spondyloarthritis, patients are usually tried on non-steroidals. So usually we ask them to try 2 different non-steroidal medications for a period of 6 weeks. and of course with physical therapy. And if they don't respond to that, usually the first line of therapy that we use is TNF inhibitor. One, because they have been out for the longest amount of time in terms of biologic, and we are more comfortable using them. We have good data for patients using them for 15, 20 years. And of course, if they don't respond, then we switch them to IL-17A inhibitors. And JAK inhibitors, as I mentioned, have been just approved in the last few years only. And in terms of psoriatic arthritis, so for psoriatic arthritis, if psoriasis is the main problem, the IL-17 inhibitors and IL-12/23 inhibitors and IL-23 inhibitors work great. Patients have like 95% skin clearance. So if skin is the major issue, we usually try to go with these agents. TNF inhibitors work a little better if arthritis is the major problem. And again, if uveitis is a major problem, then we go with certain TNF inhibitors like adalimumab.
Very good. There are some questions which are personal history type questions, and unfortunately, I'm not going to take those as to what should I do next. I have tried A, B, C, D, and what should be my next choice, and those types of questions I'm going to avoid. But there are some very interesting questions about sausage appearance and what does that mean. And I think this particular questioner thinks that the sausage toes or sausage fingers is something to do with the nails. And I just want to say that no, it's the entire finger or the entire toe is swollen, not just the nail. And it's basically because the three joints that we have, they are swollen, plus our tendons are swollen, and the whole thing looks like a sausage. And along the line, there was a question, and this is a very insightful question, why are nails involved in psoriasis? Why are nails a target? Anand, you want to take a crack at that?
That's an interesting question. I think so. Nail is also a sign. So we have like tenosynovitis and flexor tendon inflammation, which attaches to the nail bed, and that is a potential theory why you have like nail bed involvement with patients with psoriasis and psoriatic arthritis.
Yeah, absolutely. There are some very insightful anatomical studies which were done in England and Ireland, and they dissected out, and this is of course in cadavers, the extensor tendon that we have on our finger, and the inflammation travels along the tendon. And Anand mentioned about enthesitis. Enthesis is where the ligaments, tendons insert into the bone, and this extensor tendon of my index finger inserts at the base of my nail. And the inflammation, literally the inflammatory cells, your immune system cells, travel along this tendon and they get into the base of the nail, and that's how nail gets involved. That's a very insightful question here. So I think we are coming to the end of it. Anand, last question. What has been in your experience the most exciting development? What kind of gives you hope for the future?
So I think the most exciting development, I think there are a couple of things. One, I think in the last few years for ankylosing spondylitis and non-radiographic disease, we have multiple biologic agents that are available. And now we have an oral agent that is available. So patients who are needle phobic, don't want to take injections, I think we have something in our armamentarium that we can offer them. In terms of psoriatic arthritis, I think there has been an explosion of treatment options from TNF inhibitors to IL-12/23 inhibitors. We have new things on the horizon like combined IL-17A and F inhibitors, something called as tyrosine kinase inhibitors. So there are still multiple agents that are in the pipeline for clinical trials. Because as we saw, not everyone responds to these agents. There are like 40% of patients who might not respond to a certain medication. So there's still an unmet need to treat these patients who don't respond to the available agents. And I think that's really exciting with the new therapies that are coming down the pipeline.
Excellent. I also kind of feel hope mainly because of this the question that we already answered, that we not only are treating now the patient's signs and symptoms, but we are changing the course of the disease. the drugs actually are absolutely changing the course of the disease. We are not seeing patients getting disabled. We are not seeing, I'm hoping that bamboo spine in axial spondyloarthritis is going to be a thing of past. I'm hoping that psoriatic arthritis patient getting destroyed their hands and joints, and that's going to be a thing of the past. We are never going to see that. And the new treatments are making all that available. Well, on that very hopeful note, and thank you all for joining, I need to thank all of you who joined this program. I want to be mindful of our time. John and Roz, both of you are an inspiration. Thank you very much for your stories. You are amazing, and you are role models for our patients and for me as well, and for Anand. And Anand, thank you very much for joining and your excellent talk. And first, we would appreciate your feedback. Please take a few minutes to complete this very short survey. You can do so by visiting this particular link or scanning the QR code. Very important. And please join us for this October treatment update podcast. The Clinician podcast release would be October 20th. And the patient podcast, if you're interested, will be released on date October 18th. And this will be a discussion between Roz and John and me. And then the webinars, future webinars in this program on October 19th, there is a clinician webinar, but there is no reason for you not to attend this one again. There will be two different speakers, one speaking on spondyloarthritis treatment, one psoriatic arthritis treatment update, two separate talks. And November 3 is a patient webinar again, and this is, does changing health behavior help your lifestyle, myths and solutions for that? Thank you very much for joining, and have a very good evening.